Hi, my name is Neil Dilworth, and today we're talking about cardiac emergencies in sport. We're going to go over an overview of a basic approach to the athlete that suddenly collapses or feels kind of generally unwell, atypical of an athlete in top shape, and then we're going to talk about some essentially underlying causes of sudden cardiac death and what we can do to maximize our care of athletes when such events occur. So case, we're going to start with a case number one. You're covering a football or soccer match, and as you're standing on the sideline as a first responder, either a athletic trainer, physiotherapist, chiropractor, or physician, and look out to the field, and away from the play, one of the defenders essentially collapses to the field and lies motionless. At this point, when you think what you need to do, what kind of equipment you would like to have, what you'd like to bring out to the pitch, and who you'd like to have come out to the pitch to help assess this and treat this player. Also, I want you to think about the potential differentials in terms of what might have resulted in this athlete dropping to the field. So if we gave you information such as it was a cool autumn day, athlete was known to have been well hydrated ahead of time, and going with that information, kind of approaching the athlete with the mindset of a sudden collapse. So the objectives of this talk, you want to be able to understand the symptoms that can be associated with arrhythmias. You want to be able to describe the first response approach to cardiovascular emergencies and describe the actions that you can take to maximize survival for the athlete prior to the arrival of paramedics. And hopefully that will have you understanding some conditions that can predispose athletes under your care to cardiovascular emergencies. So cardiac symptoms, most people are aware of chest pain and potentially shortness of breath or palpitations. However, they can present with essentially sudden fatigue, collapse, dizziness. They may not have any symptoms. They may also appear disoriented. Something we refer to as kind of a global hypoperfusion. So they may, in fact, with arrhythmias, have essentially kind of very vague symptoms. Feeling sick to their stomach, maybe vomiting, dizziness, blurry vision, feeling like they're going to pass out, or in fact passing out, and confusion. And you always want to consider essentially a cardiac cause when there is a witnessed sudden collapse of an individual. So when you approach that player and you come out to the pitch and you see that player lying motionless there, and they have a pulse, and you check the pulse, and it's very, very, very rapid. You don't know exactly how fast it's going, but you know that it's going way more than 100. So your rough estimate's going 150. So now that you're out there, you got a pulse. You brought out an AED, and you place the pads over the right anterior chest and the mid-axillary line on the left chest. Athletes still talking at this point, and you want to try some Valsalva maneuvers. What else might you consider? So this is kind of the supportive approach for an athlete that's lying there. So in the case where they're alert, they're still awake, they may be somewhat unstable, you don't have their vitals, but that they're able to talk and follow commands. There's very little harm in considering doing a Valsalva maneuver in a situation like this. If you have already activated the EAP, which is the Emergency Action Plan. So in this situation, knowing that you already have an athlete that has felt unwell to collapse, and they have had a rapid pulse, that should be your indication to have activated the AP so that the athlete can be essentially transferred to a tertiary care center for further assessment, evaluation, and appropriate management. So fast pulses. So there's a variety of different types of fast pulses. There's straightforward sinus tachycardia, which you're probably going to notice on most of the athletes out on a soccer pitch, or most essentially endurance or anaerobic sports. And typically that's between 100 to up to 200, which would be a very, very fast sinus tachycardia. Generally speaking, you're looking at, from a treatment perspective, resting the athlete if symptomatic, assessing their temperature to make sure that they're not showing signs of heat exhaustion or heat stroke, and fluids as necessary. Certain contributing factors, obviously, reduced rest, overexertion, temperature, and not being well hydrated, and obviously if they have any kind of trauma, any loss of blood could also cause a sinus tachycardia. There is another related condition called POTS, postural orthostatic tachycardia syndrome, which can also cause essentially an exertion-related tachycardia. Generally speaking, they'll have a lot of those patients will have a lot of difficulty with any kind of exertion and are less likely to be participating in sport. But it's something to consider, as it can happen in adolescence or young adulthood. So it's something that can develop in athletes as they're going along. Ventricular tachycardia, so that's essentially a wide complex. When you take a look at the QRS complex, tachycardia would be anywhere between 120 to 150. That is a shockable rhythm, and it can be identified by AED. These patients can be stable, so you have patients that come in and out of ventricular tachycardia, and they may feel palpitations, they may feel dizziness, lightheadedness, or sometimes they may not be that symptomatic. But generally speaking, from an exertion standpoint, where you're requiring increased blood flow to the muscles, generally speaking, those athletes will be symptomatic when they have that. Supraventricular tachycardia is a rate. Typically, it's much greater than 100, but it can be 100 to 270. And for treatment for these, classic described are the vasovagal maneuvers, so such as blowing into a straw, the dumping an ice bucket of water on somebody's head. And there's a newer version, which we'll show a video later, of where essentially you have them blow into a syringe while at the same time leaning their torso back and lifting their two legs at the same time. And the combined maneuver is shown to be somewhat more effective than either the carotid massage or the other vasovagal maneuvers that we mentioned before. Then medication-wise, adenosine. So typically with the first dose 6 milligrams and repeat dose 12 milligrams. And once again, that's not typically something we're using at this side of the pitch. If you have advanced care paramedics, they may be able to essentially identify the rhythm on the field side with a monitor and administer the adenosine. So the contributing factors to supraventricular tachycardia are atrial conditions such as flutter fibrillation, AV node reentry, and junctional rhythms, as well as Wolff-Parkinson-White. And then the last one we'll talk about today is ventricular fibrillation, and these patients are pulseless. Typically the rate is greater than 200. This is also a shockable rhythm that's identified by a defibrillator, AED. Multiple contributing factors, CPR and AED are a must. Similar with ventricular tachycardia, when you attach the AED and you go for a rhythm check, the AED will identify the rhythm as shockable and then advise a shock. So you will charge the machine, and once it's charged, make sure everybody's clear and apply the shock, at which point you want to essentially resume the CPR immediately. So the player that you approach now on the field essentially does not have a pulse. Once again, you want to have that emergency action plan activated immediately. If you haven't already on your way approaching the athlete, start chest compressions immediately, and then get some help with somebody applying the AED stickers. When talking about chest compressions, this is kind of the most important part of cardiovascular resuscitation. So there's a few things you want to be able to do. You want to have it going at a rate of 100 per minute. In terms of the depth, you're looking at about 3 to 5 centimeters. So you want to be compressing the chest down, and generally speaking about 2 inches. When you're pressing down, you want to make sure that you're allowing for full recoil. What that does is it allows the heart to fill back up with blood before you start the next compression down, and that allows for essentially the maximal efficiency of the CPR. And then the compression to ventilation ratio should be 30 to 2, so 30 compressions to two breaths. If you have a second person present helping out, ideally the ventilation should be with a bag valve mask. Supportive measures. So once again, the important piece here is when you've identified an emergency situation, you want to make sure that your emergency action plan is activated and that it's activated earlier, so that EMS is aware and that they can start making their way over to the event. You can try a bilateral leg raise. It's roughly equal or equivalent to about 300 milliliter bolus. Consider fluids, IV fluids, if you have intravenous access. Unlikely in the majority of situations. You want to check temperature. So, for a collapsed athlete, look for predisposing conditions. So, if they have a elevated temperature, you might want to consider cooling along with your resuscitation. If you have oxygen available, that's something that you can also consider. If you can measure their O2 sats, you can use that as an adjunct. And then the final one is blood glucose. Make sure you're not missing something like a hypoglycemia in a diabetic patient which might have taken too much insulin prior to the competition. When we take a look at the ECG or the electrocardiogram, there's some basic things we want to consider. There's a number of guidelines out there. There's the Seattle criterion, and the more recent BJSM consensus paper of 2017 that talk about screening athletes with electrocardiograms and what we should be looking for. What are kind of normal variants versus what are things that are concerning for further cardiac testing and consultation. So the basic ECG abnormalities I've separated out into the following 7 categories. So waves, blocks, ST segments, QT segments, PR segments, preventricular contractions, and rate abnormalities. So when you're looking at waves, there's a couple of classic waves that are described with a couple of entities. First one is an epsilon wave that typically occurs in V2, V3, and it's associated with arrhythmogenic right ventricular dysplasia. The delta wave is a wave that is seen at the beginning of the QRS complex, and that's associated with shortened PR waves, and that's associated with Wolff-Parkinson-White. When you're taking a look at ECGs in general, you're seeing a lot of T-wave inversions, specifically in the lateral leads, V4 through V6. You want to be concerned about HOCM, hypertrophic obstructive cardiomyopathy. Same thing with abnormal Q waves that are predominant, such as needle Q waves, as they describe, with, once again, hypertrophic obstructive cardiomyopathy. For blocks, obviously second degree and third degree AV blocks are obviously a concern if we see those on screening ECG. The other one would be a complete left bundle branch block. These put the athlete at a much higher risk of having an arrhythmia during either training or competition, and therefore obviously very important in identifying on an ECG. With respect to ST segments, you can have ST elevation, which is normal, such as early repolarization. But when we're taking a look at elevation specifically in V1, V2 leads, there's a channelopathy called Brugada Syndrome, which can lead to tachyarrhythmia that we want to identify. And then the other one is ST depression, once again, and if you're seeing kind of diffuse ST depression with T-wave inversion, that's in conjunction with a HOCM as well. Then there's QT segments, so prolonged or shortened QT segments, prolonged or shortened QT syndrome. Those can also lead to essentially arrhythmias, and you want to be able to identify those prolonged. You're looking at about essentially a QT that is greater than half the length of the RR interval. PR segments, so prolonged, and we're talking very prolonged, so greater than 400, or shortened, so less than 100. Those are kind of concerning for a increased risk of arrhythmia, and you want to get a cardiac consultation for those. And then if you're doing ECGs and you're noticing a number of preventricular contractions, that's something that may also warrant essentially a cardiac consultation as well. And then finally, rates. So obviously, if you're noticing a tachydysrhythmia or severe sinus bradycardia, so resting heart rate less than 30, those are also two other things on ECG that should prompt cardiac consultation and referral. So here's examples of types 1 through 3 of Brugada syndrome. This is a genetic disorder. It can be a new mutation, but it can also be inherited. Leads to ventricular fibrillation or tachycardia. Like I said before, you look at V1, V2, and it looks almost like a right bundle branch block. You'll have essentially an ST elevation, which you can see in the V1, V2 leads. And when you identify that, that's something that should prompt the cardiology referral. And possibly, if found to be positive for Brugada, also testing family members as well. Wolff Parkinson White, they may have a normal ECG, but obviously if you're identifying either the shortened PR and the delta wave, that should prompt a cardiac consultation. And this is a problem with the electrical pathway, and it can lead to a tachyarrhythmia. Arrhythmogenic right ventricular dysplasia. This is one of the main conditions prompting ECG pre-participation screening in Europe. Very prominent in the Veneto region of Italy. And it's an issue with the right ventricle heart muscle. There's essentially fatty infiltrate that reduces its effectiveness, and this can lead to ventricular dysrhythmias. When you take a look at the ECG, it's typically the anterior leads V1 through V3, where you can see the epsilon wave after the QRS complex. It'll also once again appear like a right ventral branch block, and you can also see T-wave inversion through leads V1 through V3. They need to be assessed by a cardiologist and have an echocardiogram. And if present, it's unlikely they'll be able to participate. Long QT syndrome, so this is a cardiac electrical abnormality, either genetic or acquired. It can result in Toussaint-Dupont or polymorphic ventricular tachycardia. A number of medications can cause long QT syndrome, but specifically the more common ones, the ones that your athletes are more likely to be on, are the tricyclic antidepressants, which may be on for either headache management or for a neuropathic perspective. And then there's three antibiotics that are more commonly seen to cause it. So azithro, chlorithro, and erythromycins can all cause prolonged QT. So this is something you can find obviously on ECG, and these athletes, once again, you should have them referred to see a cardiologist, as obviously the risk of having a cardiac event is elevated. It's a rare condition called Catecholaminergic Polymorphic Ventricular Tachycardia. This is an inherited arrhythmia, and where essentially either with exertion or emotional induced adrenergic surge leads to essentially a dysrhythmia. It can be a cause of sudden cardiac death, but it can also lead to essentially sudden syncope, or like we talked about before, those kind of global hypoperfusion symptoms, where the athlete might feel like a change in vision, feeling dizzy, lightheaded, vomiting, or nausea. This requires referral to cardiology as well as a thorough workup, including genetic and stress testing. Hypertrophic obstructive cardiomyopathy. This is one of the commonest causes of sudden cardiac death in the United States. It's where you have a normally thickened left ventricular wall. It can obviously cause sudden death, like we talked about, but it requires ECG screening. Typically see needle Q waves. There's typically left axis deviation, but T wave inversion and signs of left ventricular hypertrophy. You can see on the example below, the other one they may have is some ST depression as well. You can see on the leads below, you can have, there's V4 through E6, essentially T wave inversion throughout, as well as throughout the very least 2, 3, and AVF. Myocardial infarction, so this can happen at any age, and you can also have essentially acute coronary artery dissection that can occur as well. But in terms of myocardial infarction, more common in masters athletes in endurance sports. It's essentially ischemic event of coronary arteries, which supply the heart. Once again, although chest pain should prompt you to think of myocardial infarction, they may present with profuse sweating, vomiting, dizziness, or once again sudden collapse. So for pulse and awake, if you have aspirin, make sure you give them 160 or 325 to chew. Activate that emergency action plan and call for an AED early, and attach while waiting for transfer in case they become unstable. Obviously, if they don't have a pulse, you want to start CPR immediately. Sickle cell syndrome. So this is a condition whereby the red blood cells do not form normally and put the patient at risk of essentially both a number of crises and acute pain syndromes, because essentially the sickle cells get stuck in the capillaries, leading to ischemia. And this can be exacerbated by exertion and dehydration. These patients typically require not just rehydration, but a significant amount of analgesia and opiates, and will typically classically require transfer to the hospital. Commotio Cordis. This is essentially a mechanical cause of a dysrhythmia, where there's a direct blow to the chest overlying the heart, and the sudden compression leads to dysrhythmia and then eventually arrest. It's a rare condition. Baseball, interesting enough, has the highest reported incidence in the U.S., and that's specifically with a baseball hitting an athlete in the chest. But once this occurs, the athlete requires immediate CPR and early defibrillation. In summary, once again, identifying the sudden collapse as a prompt to activate your emergency action plan and call for emergency medical services. Make sure you have an AED on hand. CPR, the quality of the compressions is so important. So make sure you practice not just the rate, but also the depth of the compressions. And finally, consider other supportive measures while you're waiting for paramedics to arrive. Thank you very much. Here's some references from the lecture you can take a look at. There's the BJSM article from 2017, Seattle criteria, and a couple of specific articles on CPVT and Commotio Cordis.